Hi, I'm Jill Kerr from the Society of Musculoskeletal Medicine and want to have a discussion and thinking process with you today about what to do when a patient presents with pain in their buttock. We've called this pain in the butt, but it is a challenge to therapists because if somebody comes in and they've got pain in their buttock, it could come from a lumbar spine pathology, it could come from a problem with the pelvis and the sacroiliac joint, or it could come from the hip joint because of the nerve supply to that joint and some of the surrounding structures. So I've got Warren with me today who's got pain in his left buttock. Warren, do you want to turn around to face the camera? Warren was telling me what happened to cause this pain in the buttock. He's an ex-military, as you can probably tell from his physique. He's a fit guy, but he decided to go on a ski holiday and this was a new pursuit for him. And when he was skiing, unfortunately, somebody fixed his left ski as his right leg continued to go off down the slope, and he had a sudden onset of kind of pain in the area of his buttock, which has continued to be a bit of an ache since then. We've had a look and we've cleared his lumbar spine movements. He's got full range of movement and his sacroiliac joint seems to be fine. But when we've tested his hip, he has pain at the end of medial rotation. Now that indicates that potentially there's something going on within the hip joint itself. Warren's a young guy, so we are thinking there's potential might have damaged the labrum, but he's not talking about any clicking or aching or deep ache in the groin. So from taking the whole history, we're fairly sure, and having a look at a couple of tests, that that's not implicated. So he's got what we'd call the start of a capsular pattern. There's some irritation in the joint, but the onset here has been traumatic. So the restriction of his movements is predominantly from the soft tissues. So we're going to be able to treat that with a bit of a stretch to try and improve his range of movement. So Warren, do you want to have a lie down on your back? Now, if you're stretching soft tissues, and within our approach we'd call this a grade B mobilisation because we will be working into a bit of resistance, what we're aiming to do is get rid of some of the tightness and tension within these soft tissues, but it is going to be a bit uncomfortable for the patient. So I do need to warn them that as we're stretching into his uncomfortable movement, that to expect some discomfort and not to be worried about that. You might wonder why I've chosen flexion when I've said to you that medial rotation was his most limited movement, but what we tend to find is that flexion is a very functional movement and working with this first can help to increase range.